All right, I want to thank everyone for hanging in there. We will get started on the last session. These are quick shot presentations, so we should be pretty efficient. We'll start the first presentation by Dr. Thacker, the role of calcium in augmenting the efficacy of primary hemostasis after hemorrhagic shock, from Wayne State University.
Hi, good morning. My name is Dr. Thacker. I'm from Wayne State University, and the work I'm presenting today is the role of calcium in augmenting the efficacy of primary hemostasis after hemorrhagic shock. The co-authors are listed: Dr. Lucas, Dr. Ledgerwood. Thank you for being here. And overall, we have no disclosures. Our study was a retrospective single-center cohort study, including 341 patients populated by a de-identified trauma registry. And for these patients, they were studied through three phases, phase one being resuscitation, two being sequestration, and then mobilization. And in phase one, they averaged a time of approximately 7 hours, and their average shock time with systolic blood pressure is less than 80 millimeters of mercury was an average of 34 minutes. They received an average of 14.2 units of packed cells. And at the bottom of the slide shows the actual transfusion requirement on the right being 2.5 for platelets and 6 milliequivalents of calcium per approximately 1 cooler massive transfusion, or 5 units of packed red cells. Overall, this table just shows the duration, showing that most patients stayed, or the average duration in phase one was 7 hours. Phase two is just over a day at 29 and almost 30 hours. And they spent a few days in fluid mobilization. Our analysis was performed via bleeding time, via the template bleeding time device. Platelet proteins were analyzed via immunoassays, the aggregation via an aggregometer, and all these studies were done at time of collection of the blood. During phase one, these were some of the average parameters. And once again, it's approximately 7 hours, 34 minutes during shock, stayed with a systolic blood pressure less than 80, and they received approximately 15 units of red cells, an average of 7.5 units of plasma, and almost 4 units of platelets. And they did get significant calcium repletion as well. Overall, throughout the phase of resuscitation and recovery of the patient, what we noted was that the variables measured, such as platelet count, MA, ADP, and MA collagen, as well as beta thromboglobulin, which is just a surrogate for platelet release factor, as well as platelet factor 4, once again, same as before, as well as bleeding time. And we showed that the ionized calcium corrected for pH, which is the CIC, as compared to total serum calcium, did correlate significantly, whereas the total serum calcium did not significantly correlate, showing that the ionized calcium was a better metric, and specifically ionized calcium corrected for pH. This is a table demonstrating the former data, which shows that patients with low platelet counts, it correlated with them also being hypocalcemic. And this was the data here for the calcium was more so with the ionized calcium corrected for pH, and these were significant values. Once again, this shows that the platelet release factors did also correlate with the ionized calcium in the patients, and these were significant as well throughout the 3 phases. Once again, this is a demonstration that with low calcium in phase one, and as the calcium recovered and also was supplemented, that the aggregation and overall platelet function improved as well. In summary, hemorrhagic shock itself, as well as balanced resuscitation through massive transfusion, causes or is correlated with low ionized calcium corrected for pH, and that calcium level correlates directly with the platelet level, platelet aggregation, platelet release factors, and inversely with the bleeding time. Finally, balanced resuscitation regimens for traumatic shock should include calcium supplementation, and overall should include empiric calcium as well as supplemental calcium to correct any further deficiency. It would be recommended that this is given as an infusion, not as a bolus, and that overall throughout the resuscitation of bleeding trauma patients should be focused on operative management as well as correction of coagulopathy and supplementation of calcium. Thank you.
Question.
I have one. Can you help me understand the role of supplemental calcium in the era of using whole blood for trauma resuscitation? Thank you.
So in the era of using whole blood, to my knowledge, at least at the current, mostly military is the only modality that uses whole blood for resuscitation. There's actually a significant portion of literature now that shows that depending on the area of the country in which you are, some patients are given plasma in the field, some are given crystalloid in the field. And so with respect to whole blood transfusion, it would still not account for the hypocalcemia that may be secondary to the hemorrhagic shock insult, although whole blood transfusion may be something that may remedy the hypocalcemia and platelet dysfunction caused by transfusion of red cells.
Hi, Jasmine Paul, Albuquerque, New Mexico. Excellent presentation. This is something that I think a lot of trauma centers are thinking about is what's the role of calcium in our resuscitation. So when do you suggest that we actually give the bolus or infuse of calcium? Is it right when we initiate the massive transfusion protocol after a certain number of units, time? What's the ideal place for it?
I think that it's an overall ongoing discussion and something that in essence is the story of a chicken and the egg, to make it somewhat simple, in the sense that the traumatic shock or the mechanism of injury is something that could cause coagulopathy and hypocalcemia in and of itself. Also, blood transfusion could also cause this as well. And it's difficult to discern which is the predominant and dominating factor in all of this. And also resuscitating a bleeding trauma patient is a dynamic process in and of itself. So to answer your question more directly, I think that the most prudent thing to do would be to give empiric calcium with blood transfusion, especially the patients who are receiving more than 1-2 individual units of packed red cells, those that are being actively resuscitated, and that you would want to monitor their calcium levels throughout the process and add supplemental calcium to this. So I think that the overall goal would be to incorporate calcium empirically as part of massive transfusion protocol, and that overall that the goal would be to supplement when necessary or when it would add benefit based on lab values.
Thank you.
Thank you.
Thanks.
Next talk by Dr. Brenner. A balloon rises above resuscitative endovascular balloon occlusion of the aorta at zone 1 may be superior to resuscitative thoracotomy.
Thank you. I'd like to thank the association for the opportunity to present our work. These following are my disclosures. So REBOA has now been performed in the United States by trauma surgeons for trauma patients for over a decade. We've been collecting data with the AAST aortic occlusion trial, which is enrolling resuscitative thoracotomy patients as well as REBOA patients. Our aim today was to compare outcomes of REBOA at zone 1, which is when the balloon is occluded at the distal thoracic aorta, and compare this with patients who received resuscitative thoracotomy and looked across different various injury patterns. The comparison groups were from 2013 to 21. Roboa versus resuscitative thoracotomy, which also included an aortic cross clamp for aortic occlusion. We used the following methods for the statistical modeling, as well as institution weighting for trauma admission number, as well as ACS trauma level designation. We used inverse probability treatment of weighting to control for demographics and physiology, including admission Glasgow Coma scale, systolic blood pressure at the time of aortic occlusion, injury severity score, CPR at the time of aortic occlusion, and blood product transfusion. And we looked at the following outcomes, both in blunt and penetrating, as well as abdominal injury with or without TBI and with or without thoracic injury. The abbreviated injury scores were above 2, so these were at least moderate to severe injuries in the thorax and the head. So the institution characteristics, and this is something that we've seen over the past 10 years, the trend continues. The majority of Roboas being performed overwhelmingly are coming from 3 institutions, and this continues to be the case. 80% of those occur in institutions who are doing very, very few Roboas, and in fact, less than 10. The demographics, not surprisingly, were found to be different between the resuscitative thoracotomy and the Roboa patients, both in admission vital signs, initiation vital signs, as well as response to aortic occlusion. The characteristics such as CPR in progress at the time of aortic occlusion, as well as the duration of the initial aortic occlusion, were found to be different. The outcomes between the 2 groups also not surprisingly different. So this led us to perform the logistic regression model. And what we did was take the variables that were different between groups and were able to control those, because now after 10 years, we finally have enough patients to be able to do this. So the independent covariates we found was that there was a survival benefit between a survival benefit for the Roboa patients compared to resuscitative thoracotomy patients for admission, and those that came in with the admission GCS lower, not surprisingly, had worse mortality, as well as those who came in and had CPR during aortic occlusion. For penetrating injury, we found similar trends. There was a survival benefit for the Roboa patients, regardless of whether they had abdomen, non-TBI, non-chest, or isolated abdominal injury. Also, CPR during aortic occlusion was significant, as well as duration of aortic occlusion greater than 90 minutes. Our propensity weighted match ended up being a 1-to-1 based on the characteristics of the Roboa and the resuscitative thoracotomy patients. Overall, we found a survival benefit for the Roboa zone 1 patients compared to the resuscitative thoracotomy patients across all various types of injury and injury patterns. So in conclusion, for blunt injury, overall and isolated blunt abdominal injury, resuscitative thoracotomy had a higher odds of mortality than Roboa. Other risk factors that were associated with mortality in blunt trauma were age greater than 55, lower admission GCS, CPR at the time of aortic occlusion, and duration of aortic occlusion greater than 90 minutes. For penetrating injury, we also saw that overall resuscitative thoracotomy had a higher odds of mortality than Roboa, and resuscitative thoracotomy was associated with higher odds of mortality in isolated abdominal injury compared to Roboa patients. And again, not surprisingly, duration of aortic occlusion greater than 60 minutes was associated with a higher mortality after isolated penetrating abdominal injury. So looking at age specifically, age greater than 55 is significantly associated with mortality in blunt overall, blunt without TBI, and isolated blunt abdominal injury. Duration greater than 90 minutes of aortic occlusion is associated with a higher odds of mortality in overall blunt and overall penetrating injury compared to duration of aortic occlusion less than 30 minutes. Finally, duration of aortic occlusion greater than 60 minutes is significantly associated with mortality in penetrating non-thoracic injury and isolated penetrating abdominal injury compared to a duration of aortic occlusion less than 60 minutes. Thank you.
Questions?
Jerkovich, Sacramento. Thanks, Megan. Did people with a Roboa none of them have a resuscitative thoracotomy? Is that true? Was it really black and white like that?
So we've been struggling since the beginning to try and tease these
Yeah.
patients out. So we finally have enough to be able to do that after 10 years, but we took just the patients who got a Roboa and just the patients who
Okay.
got resuscitative thoracotomy. Even still doing that, we still saw the significant differences at baseline, but now we finally have enough patients that we can do a true, a weighted and matched control to actually find the thoracotomy patients with the same physiology as the Roboa patients. And that's how we ended up with our weighted
Yeah.
logistic
I look
regression.
forward to reading the paper. One last question. I'm sure it bothers you. It's troubling to me that 3 institutions totally dominate this data set. And that leads to several questions, one of which maybe those 3 institutions are just better at resuscitating, morbid trauma patients, forget Roboa, maybe they just are. Or maybe Roboa just isn't catching on in the country for some technical reason. But it isn't these. I mean, there's a lot of reasons for it. I just don't know what it is, but it's troubling to me.
I agree. That's exactly the sentimental approach we have. It's a little bit troubling. The problem with the AAST trial, as like with all multi-institutional trials, it's a voluntary database, right? So the 3 institutions that represents the high volume Roboa institutions, but it's not capturing all the Roboas that are performed, right? If we look at the TQIP data, we're missing 60% of institutions that are actually also doing Roboa. So that is probably more troubling that we're just, the aorta trial is just these, continues to be these institutions. But, voluntary research and resources are slim. So this is the best we can do. But there's a lot of selection bias that we can't necessarily get at from these statistics, but hopefully by doing them more, it'll certainly help. And I think the technology is advancing now that we have a 4 French Roboa catheter. We may also see that next, rise in the implementation curve. So more to come. Thank you.
Hi, Mahmoud Malas. I'm a vascular surgeon by trade from UC San Diego. So I would just say first, congratulations. This is a really, as you're going through, I was going to ask you about propensity score matching. You did that. So you answered that. You did every possible analysis. So very well done. I would say he kind of asked my second questions, but I will just kind of rephrase it. How do you think we could just clearly, I think Roboa is going to have an impact, a positive impact, reducing mortality compared to thoracotomy. It's just no brainer. But how do you kind of disseminate this throughout the country? And the other thing I can tell you from, of course, we do a lot of this with rupture aneurysm. We deal this with, this is where it really came from, Roboa. So how do you, like typically what we do, we put the balloon up, stabilize the patient, shoot a quick angio, and then move the balloon down. So you showed that the time of occlusion was very strongly associated with increased mortality. Is there a way to kind of disseminate this into trauma? So do you really have to have the balloon all the way up in the thoracic aorta, or is it can be moved down? Because probably a lot of them are, if you clamp the aorta at 90 minutes and you're not perfusing anything, of course the patient is going to die. So how do you kind of, move it down maybe, below the renal or supraciliac?
Great questions. Thank you. So there is a large movement and a lot of studies happening right now with partial Roboa. So that's basically where the balloon goes up at zone 1, but it's either inflated 50% or it's inflated fully and then deflated and then inflated fully. So the reason why it stays up at zone 1 is because there's intra-abdominal hemorrhage that sometimes is from multiple sites. It takes longer, right? The ruptured AAAs, we know when we're going in where that source of hemorrhage, and because it's one source of hemorrhage, probably quicker to take care of, give or take. Obviously, they can be complex. But in the cases where there's intra-abdominal and pelvic injury, the balloon goes at zone 1. We do the X-slap, fix the abdominal hemorrhage. And if there's still hemorrhage in the pelvis, then we move the balloon down, inflate it, and then do the angio and the embolization. So it's certainly different than the ruptured AAA because we know what we're doing when we go in for the ruptured AAA. The hemorrhage is occurring in one specific spot and it can be taken care of. But the other argument, which I discuss with my trauma colleagues, is that, the ones that they're interested in partial Roboa, when, in vascular surgery school, you learn to put the balloon up, take care of the hemorrhage, and take the balloon out as quick as possible to avoid that 90-minute increase in, mortality. So it'll be interesting to see what the partial Roboa data shows. And maybe that can translate not only in trauma, but back to vascular, where we might be able to get those patients off the table, even though they have an aortic occlusion that's prolonged. Thank you.
Our next speaker, Dr. Al-Sayed, I apologize if I mispronounce that. Women experience higher rates of mortality following thoracic endovascular aneurysm repair from UC San Diego.
Good morning, everyone. Thank you for the opportunity to present our work. I have no relevant disclosures. Endovascular repair of thoracic and thoracoabdominal aneurysm have been increasingly adopted due to the lower mortality rate compared to open repair. According to prior literature, women usually present with smaller aortic diameter, but greater aneurysm growth rates compared to male patients. Women also experience a higher risk of mortality, stroke, and postoperative complications following aortic arch repair. Women with thoracic aortic aneurysm are 3 times more likely to experience dissection and rupture. In patients undergoing open and endovascular aneurysm repair, unfavorable neck anatomy was found more frequently in women with neck length less than 15 millimeter and an angle of more than 60 degrees. Women experienced higher mortality rates compared to men following open and endovascular aneurysm repair. They also experienced higher renal, cardiac, and pulmonary complications following endovascular repair. There was also 2-fold increased odds of developing type 1 endoleak in women patients compared to male patients. Female gender, however, had no effect on long-term reintervention or survival following endovascular aneurysm repair. A prior observational study of the NSQIP database from 2005 to 2011, including 649 patients undergoing TVAR, showed no difference in adjusted mortality between women and men. Given the complexity of endovascular repair that is going nowadays and the introduction of fenestrated and branched EVAR, we wanted to explore the outcomes of TVAR and complex EVAR in women versus men. We included all patients undergoing TVAR and complex EVAR between 2003 and 2018 in the VQI Vision database. Study group included males and females. Primary outcomes were perioperative and 1-year mortality. Secondary outcomes were in-hospital spinal cord ischemia, myocardial infarction, stroke, and 1-year aneurysmal rupture and reintervention. Multivariable logistic regression was used to assess in-hospital and perioperative outcomes. Kaplan-Meier survival and Cox proportional hazard regression analyses were used to assess 1-year outcomes. Around 5,000 patients were included, 3,000 were male, 2,000 were females. Female patients were more likely to be Black or African American with a history of COPD and chronic kidney disease. They were also at higher rates of being symptomatic on presentation. They also presented with smaller aortic diameter. Male patients were more likely to be on preoperative medications such as aspirin, antiplatelets, statins, ACE inhibitors, and anticoagulants. After adjusting for potential confounder, female patients were at higher risk of postoperative stroke and mortality. At 1 year, female gender was still associated with higher risk of adjusted mortality. On univariable analysis, female gender was associated with higher risk of reintervention. However, this risk was not statistically significant after adjusting for potential confounders. This is the Kaplan-Meier survival for mortality for female versus male patients, and the mortality was slightly higher for female patients at 1 year. The limitations of this study is due to its retrospective nature, we can only report associations. Also, we don't have adequate anatomical data that may explain the unfavorable outcomes in female patients. So in conclusion, mortality after TVAR and complex EVAR seems to be higher in female patients at 30 days and up to 1 year follow-up. Female patients also face 2 times a higher risk of in-hospital stroke. Future studies with more granular data and more data on anatomical features associated with these unfavorable outcomes are rented to explain, to give us more wide picture of why we have this unfavorable outcomes. Finally, I would like to thank my mentor, Dr. Mulas at UCSD, and my colleagues at Center for Learning and Excellence in Vascular and Endovascular Research.
Questions? So I am not a vascular surgeon, so I'll preface that by saying that the question I had was, you know, in multiple other studies outside of surgery, we find that female patients seem to face kind of a gender bias in terms of all disease processes, stroke being one of the most common, underidentified, undertreated. Are we seeing a similar effect in this population? Is the vascular approach to these patients incorrect? I guess I don't know how to word that better, but if you know what I mean.
Okay, thank you for the question. So I think one possible reason is that female patients have different anatomy than male patients. And usually, especially in endovascular procedure, these devices are mainly made, taking in consideration the male anatomy, but they didn't actually take in consideration that the female anatomy may be different. And I think this is something that should be taken in consideration when making these devices, because yes, female anatomy is different and they have more difficult, but we need to maybe stop saying that and make devices more accommodating for female patients.
Thank you.
Thank you.
Our next speaker, Dr. Lattimore, will be presenting the impact of geriatric specific variables on long-term outcome in patients with hepatopancreatic, biliary, and colorectal cancers selected for resection.
Hi, and thank you for the opportunity to present our work at this year's Western Surgical Meeting. We have no disclosures. Geriatric patients age 65 and older are the fastest growing population in the United States, which inevitably means that there will likely be more cancer diagnosis and need for major intra-abdominal operations. In 2014, the ACS-NSQIP developed preoperative geriatric specific variables in an attempt to predict and prevent morbidity in this population. Geriatric specific variables have been found to be associated with short-term outcomes such as increased discharge to a facility and reoperation. But there are very limited studies examining geriatric specific variables in the context of long-term survival. The purpose of our study was to determine the association between 4 geriatric specific variables and 1-year survival in our HPV and colorectal cancer surgical populations. The 4 geriatric specific variables we used were use of a mobility aid, history of preoperative falls, living alone, and having someone other than the patient sign their surgical consent. Using an institutional database, we identified all patients 65 years and older who underwent an HPV or colorectal operation for cancer from 2014 to 2020. We merged this data with ACS-NSQIP and geriatric surgery research file data and broke the patients into 2 groups, those with no geriatric specific variables and those with 1 or more. The primary outcome was 1-year mortality and secondary outcome was discharge to a facility. On univariate analysis of patient characteristics, there was only a difference in sex, with significantly more female surgery patients having 0 geriatric specific variables compared to males. Notably, the probability of morbidity and mortality were not significant between those with no geriatric specific variables and those with 1 or more. Continuing with the univariate analysis, we did not find any differences in patient outcomes between those with 0 geriatric specific variables and those with 1 or more. On our multivariable analysis, we found that those who underwent an HPV operation were 2 times more likely to die within 1 year compared to those who underwent an operation for colorectal cancer. The only geriatric specific variable associated with increased odds of 1 year mortality was having a surrogate sign their consent. Discharge to facility was also associated with 2 times increased odds of 1 year mortality. On multivariable analysis of our secondary outcome, discharge to facility, we found that increasing age, HPV operations compared with colorectal cancer were associated with increased odds of being discharged to a facility. The geriatric specific variables living at home alone and using a mobility aid were associated with 3.3 and 4.5 times greater odds of being discharged to a facility, respectively. We created Kaplan-Meier survival curves for all 4 of the geriatric specific variables and discharge to facility, and found that only discharge to a facility was associated with a significantly decreased probability of 1 year survival compared with those who were discharged to their home. So in conclusion, increased risk of mortality at 1 year was associated with having a surrogate sign the surgical consent and being discharged to a facility. Being discharged to a facility was associated with living alone and use of a mobility aid. Patients who had HPV resections were more likely to be discharged to facilities and to die within 1 year compared with colorectal patients. And overall, our data emphasizes the importance of preoperative patient optimization and social interventions, as well as setting expectations that drive joint decision-making and patient care, especially those that are at risk for being discharged to a facility postoperatively. Thank you, and I'm happy to take any questions.
Question.
I have one for you. Several of your measures are basically surrogates for frailty. And we often assess frailty in the office when we're seeing a patient formally, and sometimes we do it a little bit more informally. Do you think that there is a role for more formal frailty assessment and rehabilitation to improve the results? Thank you.
Thank you for that question. So the modified frailty index score has been used over a few studies in the past, and these geriatric specific variables are a little bit more of a new measure. But I do think that we're trying to figure out what is the best way to assess if a person does qualify as being frail. And a lot of that is not based on hard metrics. It's really just what we see in the clinic setting. And so I do think that it would be appropriate to have more hard data to assess whether or not somebody is considered to be frail.
So following up on that question, would using more than one score, right? You split your group into 0 versus 1.
Right.
Would a second group, let's say above 2 or above 3, be a better measure?
I think that that's a really great point. And I think that if we were to divide them into, because we only used 4, so if we were to divide them into all 4, we would probably see a difference there.
Thank you.
Yeah.
Next, Dr. DeGraff will be discussing sleeve gastrectomy at the time of liver transplant, early experience and results from Mayo Clinic.
All right. Well, thank you very much. I'm Luke DeGraff. I'm one of the surgery residents at Mayo Clinic, Arizona. I'm appreciative of the association for allowing me to present our early experience and results looking at simultaneous sleeve gastrectomy at the time of liver transplant. I have no conflicts of interest to disclose. Now, it's been clear for some time that obesity is an ever-growing epidemic within the United States, with prevalence in some areas now exceeding 40 to 50%. And one of the complications of morbid obesity is non-alcoholic fatty liver disease, which also in some studies is shown to affect up to 40% of the population. There's a subset of non-alcoholic fatty liver disease that is known as non-alcoholic steatohepatitis, or NASH, and that's characterized by an inflammatory stage of liver disease, which leads to progressive liver fibrosis, cirrhosis, and potentially eventual liver failure. And NASH, now present in 2 to 5% of the population, is currently the fastest growing indication for liver transplant in the United States. However, severe obesity, which is defined as a BMI of over 40, is considered a relative contraindication for liver transplant, because studies have shown increased postoperative morbidity and mortality with increased rates of respiratory failure, infection, and non-operative biliary complications. Likewise, cirrhosis greatly increases morbidity and mortality in bariatric surgery. So either of these procedures independently is prohibitively risky for these patients, and typically bariatric patients with liver disease are not considered to be good candidates for either. However, simultaneous liver transplant and sleeve gastrectomy may allow performing these two life-saving procedures that would not be performed independent of one another. And sleeve gastrectomy enables the performance of ERCP in the early transplant period and should be the bariatric operation of choice for this reason. So the aim of our study was to present our initial experience and bariatric outcomes for patients undergoing simultaneous liver transplant and sleeve gastrectomy. We maintain a prospectively collected database of all of our patients undergoing bariatric surgery at our institution, and we retrospectively queried this database to include all patients who underwent simultaneous liver transplant and sleeve gastrectomy. Weight loss, metabolic, and surgical outcomes were analyzed. Looking at our patient characteristics, we had 7 males and 6 females in our cohort. Obviously, the vast majority of liver disease was due to NASH with or without some other underlying etiology, such as autoimmune hepatitis, alpha-1 antitrypsin deficiency, hepatocellular carcinoma, or alcoholic liver disease. The median MELD was 18. 4 patients received livers from donors who were deceased after cardiac death, and 9 patients received livers from donors who were deceased after brain death. Most of the comorbidities seen in our patients were related to their underlying liver disease, namely hepatic encephalopathy, esophageal and rectal varices, portal and mesenteric vein thrombosis, thrombocytopenia, and ascites. The comorbidities associated with obesity were more scarce, namely metabolic syndrome, hypertension, diabetes, but GERD and OSA as well. Looking at the operative and hospital course, the mean ischemic time for our donor livers was 5.36 hours. The median ICU length of stay was 3 days. The median hospital length of stay was 9 days. We had a median follow-up of 2 years. The mean BMI for our patient cohort preoperatively was about 47, and you can see that postoperatively patients lost weight with an estimated weight loss of about 60%. Looking at the graph of estimated weight loss over time, you can see that their estimated weight loss after surgery appears to be sustained over the following years, but there is a trend towards weight regain the further out from surgery patients get. And again, reflected in their BMI, there's an initial drop in BMI after surgery with sustained weight loss, but tends to trend more towards weight regain the further out from surgery patients get. Looking at complications, the majority of these complications are associated with the liver transplant. Almost everyone in our cohort developed biliary strictures, necessitating ERCPs for balloon dilations and stents. Other common complications include the requirement for hemodialysis in the ICU, take back to the OR for postoperative hemorrhage, and superficial wound dehiscence, which may be related to their overall immunosuppressed state. The only significant bariatric complication that we saw was one person who developed gastric stenosis requiring balloon dilation at 6 months, and ultimately conversion to a Roux-en-Y gastric bypass by 2 years. So in conclusion, simultaneous liver transplant and sleeve gastrectomy appears to be a feasible strategy for obese patients who have advanced liver disease, and it provides 2 simultaneous life-saving procedures that may not be performed independent otherwise. It allows the treatment of the underlying disease of chronic obesity, which led these patients to develop their liver failure in the first place. The majority of patients, again, experienced complications, most of which were transplant related. There were no incidences of mortality in our cohort and no major bariatric related short-term complications that we were seeing. So it indicates that sleeve gastrectomy appears to be safe to perform at the time of liver transplant. Thank you, and I'd be happy to take any questions.
Questions?
So how do you sequence that? I'm guessing you do the liver first, and if everything goes well, you then do the gastric sleeve. Is that correct?
Yes. So the liver transplant takes precedence in these patients, and there actually 4 of our patients went back to the ICU overnight for resuscitation, correction of their coagulopathy, and were taken back either later in the same day or following day to wash them out and perform the sleeve gastrectomy at that time. But if the transplant goes well, the liver gets in, then we do the sleeve gastrectomy following that in the same operation.
Kent Van Sickle from San Antonio. Enjoyed that presentation. That is an interesting solution to a worsening problem, right? We're seeing just more and more obese patients in general, and it's affecting transplant procedures. So I'm just curious, it looked like the majority of these patients were getting sleeves because their BMIs were high, not necessarily because they were sick from their obesity, right? There are only 2 diabetics,
Right.
maybe 1 with high blood pressure. So was NASH their primary obesity related problem? And if so, in this cohort, did you follow them with liver biopsies in their transplanted livers? Are you doing ultrasounds on their livers to see, does any element of NASH or NAFLD creep back into these patients after transplant, and even more specifically after weight regain?
So for your first question regarding the comorbidities, I think part of the reason why we may not have seen such components of metabolic syndrome like hypertension is kind of because of their underlying liver disease. So a lot of these patients were on diuretics at baseline for ascites. They didn't require antihypertensives, and they didn't come in with a diagnosis of hypertension, but they may have developed it later on once they started to become more healthy. So yes, NASH was their presenting kind of comorbidity related to their obesity. Regarding the long-term follow-up with ultrasounds and liver biopsies, that's something that I think needs to be looked at. Of course, I would anticipate that the redevelopment of NASH may occur in some subset of these patients, but that's going to be a process that occurs over years, maybe even decades. So that's something that I think with our small sample size and follow-up of 2 years at this point, we can certainly go back and look. I'm not sure if we would be able to see that at this point, but something that maybe kind of once we have years of data to go back and look at might be worthwhile.
We've clearly shown a decrease in NASH.
Yeah.
Thank you.
Thanks.
Our final talk by Dr. Geisel. Does ACOSOG Z11 criteria apply to patients with ER negative breast cancer?
Good morning, everyone. I'm Lauren Geisel, PGY3 from Orlando Regional Medical Center, and I'll be presenting on does the ACOG Z11 trial apply to ER negative breast cancers? And thank you to the Western Surgical Association for allowing us to present this work. Okay, I have no financial disclosures or conflicts of interest. So the Z11 trial is very well known in the breast surgery population. So this looked at axillary lymph node dissection and that it could be admitted for a specific subset of breast cancer patients. So T1 and T2 breast cancers that had 1 to 2 positive sentinel lymph nodes, and then received that were planning to receive adjuvant chemotherapy and radiation after a lumpectomy. However, 70% of this cohort was ER positive tumors. So how does this apply to high risk groups such as ER negative, the bad actors in the crowd? So we conducted a large hospital-based study to evaluate whether axillary lymph node dissection can be omitted for ER negative patients that had positive sentinel lymph nodes. And this is just an overview of that. But so 86.3% for the sentinel lymph node group in the study had a 10-year survival. And then for the axillary lymph node dissection, it was 83.6. And there was no statistically significant difference. So we queried the National Cancer Database and looked at 5,026 patients who were diagnosed with T1 and T2 ER negative breast cancers. These patients were treated with lumpectomy, chemoradiation between 2012 and 2018. All the patients had negative margins at the time of their resection, and they were grouped into 2 categories, either a sentinel lymph node group that had less than 5 lymph nodes, or axillary lymph node dissection with greater than 10 lymph nodes. The 6 to 9 lymph node area was excluded, and this is based on prior research that's been done. We used a Kaplan-Meier method curve and a log rank test, and we looked at overall survival between these groups, and then used a multivariable Cox proportional hazard model and analysis. So this is a summary slide showing statistics between the sentinel lymph node group on the left and the axillary lymph node dissection group on the right. The majority of patients in both groups were between the ages of 50 and 70. Additionally, the majority of patients received their care at a comprehensive community cancer center. So we also looked at between the 2 groups, the number of lymph nodes that were involved. So for the sentinel lymph node groups, these had 1 to 2 lymph nodes involved. And then you see the axillary lymph node dissection group, 47.7% had greater than 3 lymph nodes involved. And the majority of breast cancer patients were also triple negative, and that was true for both groups. This is a Kaplan-Meier curve showing the sentinel lymph node and axillary lymph node dissection groups. There was no statistically significant difference when there was only 1 to 2 lymph nodes positive between groups. However, when you look at greater than 3 lymph nodes that were involved for the axillary lymph node dissection group, you do see that there's an overall increase in mortality for the axillary lymph node dissection group. And this was statistically significant with a p-value of 0.0001. Additionally, though, when you incorporate the multivariable analysis, when you look at the sentinel lymph node and axillary lymph node dissection, there was no difference in the hazard ratio between these groups with a p-value of 0.87, showing that incorporating these other factors ultimately did not change the outcome as to if a patient received a larger surgical resection. And this additionally looks at the statistical difference between the patients groups. And so for the number of lymph nodes involved, as we would expect, there was an increased hazard ratio for patients that had greater than 3 lymph nodes involved with a statistically significant p-value, and then also if there was lymphovascular invasion. So looking at the 2 groups, the majority of patients were within a similar age population between 50 and 70 years old. For the sentinel lymph node group, this was 61.7%, axillary lymph node dissection was 58.3%. This is similar to the Z11 trial for the age distribution. However, the Z11 trial did not incorporate a greater than 70-year group, which was completed in our study. Additionally, the majority of patients for both groups had triple negative disease. And then the 5-year overall survival, when looking at just the Kaplan-Meier curve, was statistically significant between the sentinel lymph node and the axillary lymph node dissection. However, when you take into account the multivariable analysis, there was no survival advantage for the patients receiving an axillary lymph node dissection for the high-risk ER-negative breast tumor. So this does fulfill the Z11 criteria for the patients that have T1 and 2 sentinel lymph node positive tumors with negative margins. So despite almost half of them having a larger amount of residual nodal disease with more than 3 lymph nodes, axillary lymph node dissection did not improve outcomes for this patient population. This was overall for looked at 5-year study or 5-year survival outcomes. So in the future, we could look at 10-year survival outcomes. thank you for the opportunity to present. I'll be happy to take any questions.
Questions?
Everybody has to have a question, right? I don't do breast surgery. Am I reading this right? So most of these patients, if they had a positive sentinel lymph node, then went on to axillary lymph node. This is different than a group that automatically had an axillary node dissection.
So this was retro. So we looked at a cancer database of patients that had already had the surgery.
Right.
Yeah.
So the indication would have been a positive sentinel node that went on to axillary dissection, because that would be a different group of patients than if you just randomize patients to axillary node dissection with lumpectomy and lumpectomy
Correct. Yeah.
sentinel node that went on. So this, and that may
Mhm.
explain why you have a statistically different survival rate between the two groups, because the axillary node dissection were
Already more
potentially
morbid.
patient were already farther along.
Mhm.
Okay.
Mary Murdette from Rochester, Minnesota. So I had a question. One of the big critiques of Z11 right now is there's not actually ultrasound incorporated into it. So what could you comment on the role of X-ray ultrasound in the setting of neoadjuvant chemotherapy for these patients?
Yeah, so this, we didn't look at that unfortunately with the database, but I think for this patient population, would definitely be a benefit to do ultrasound prior to any kind of intervention. And then if there are clinically or positive nodes based on ultrasound, then you could mark those and incorporate that into your type of surgery that you choose.
Yeah, perfect. And then the ability to treat them neoadjuvantly
Yeah.
is the big strength there. But yeah, great study. Thank you.
Thank you.
Thank you.
Thank you.
Thank you all for staying, and we'll see you next year.